Welcome everyone to NISP's annual safety training update. The topics that we're going to go over today are the Columbia Suicide Severity Rating Scale, Employee Assistance Program, ligature risk training PDFs, and the policy review. We'll go over infection control, safety, fire safety, and emergency management, Health Information Portability and Accountability Act, HIPAA, and cybersecurity here at NISP. We'll go over lab safety, right to know, and additional required trainings. I realize we go over a lot at these annual training updates, but if you leave here with anything, please know that we're all responsible for one another's safety and the safety of the people that we serve. So do your best to try to pick up as much as you can. And again, thank you for listening. One of the things at the Institute that we're very proud of is the Columbia Suicide Severity Rating Scale. Many people here at NISP helped to develop and promote this tool, and it quickly assesses the treatment needs of the individuals we serve. It's a standard of care in many local and national government agencies, and it's been used in countless research studies, and it's saved many lives. The Lighthouse team here, they've left some things for you out front, and also they'll be available. If you contact us at staff development, we could also give you some of the items that they're handing out. But they've been doing everything they can to promote this tool nationally and internationally. And their lead, Dr. Posner, is here to talk to us about suicide prevention. So please join me in welcoming Dr. Kelly Posner.
So I just want to, we're here for a safety update. And I do want to say that suicide prevention is absolutely a safety and a wellness issue. And the exciting part is that everybody can be part of the solution and needs to be. So let me just set the scope of what we know about this roller coaster of suicide rates. Do you know that in 2019 and 20, even during COVID, we had our first reductions after 20 years of increases, 6% in 2020. But here's the big caveat. Those reductions were only among white Americans. Where we were seeing new crisis was among minorities. As one example, it's the number one cause of death in Asian American Pacific Islanders, 15 to 24. The CDC has told us that 5 to 11-year-old suicide is increased, but only among Black preschoolers. And then in a year or two later, it went up 4%. And the biggest accounting for that were males 15 to 24, because that help-seeking barrier in men and boys is much higher. And then the good news is in youth, unlike what people think, the rate has gone down 8%. And you can see in 10 to 14-year-olds, 18% reduction, et cetera. So we're making progress, but we have a lot more work to do. And this suicide takes more firemen than fire, more police than crime, more lives than car accidents. And 135 people are affected by every death. And those effects linger across generations because of the silence that often follows. And when we start to do this routinely, it turns the tide, it breaks the silence. And, we know that did you know that over 50% of people who die by suicide have seen their primary care doctor the month before they die? We need to be thinking about this like blood pressure, or we won't find the people suffering in silence. And the big point about that, too, is we have to have that concept well beyond the doctor. You know why? Many people who are at suicidal risk never get close to a doctor. So, for example, it's the number one cause of death in construction workers. So the unions say, let's have the safety check in the morning be more than the hard hat. Let's have it be the Columbia, right? So, and, the Columbia is policy across all 50 states, across most nations, across the continuum of care. But the main reason we're here today is because it's become the central mechanism for workforce prevention. If you take a large corporation or institution of 100,000 employees, every 6 days, an employee or a family member will die by suicide. And every single day, there will be 3 suicide attempts. So I'm going to show you, there's a Columbia Protocol app, which we're going to go through, which was highlighted by the White House as central to what the nation is doing. But the Department of Homeland Security customized the app for workforce. So if you're Secret Service or cybersecurity or border protection, they have automatic downloads on their phones. And guess what? guess what? One of the components of Homeland Security, they haven't had a suicide in 2 years since the Columbia Protocol app. But you know what the articles about it were? This is like nutrition and physical fitness. And when we start to treat this like wellness, it again helps us break down those barriers of detection. So why is the Columbia the global method of detection? One of the main reasons, it's the first time we have evidence-based thresholds for imminent risk. We did not know who to worry about before, right? So that policeman had to take everybody to the hospital. All those people had to go in those ED hold rooms who didn't need to actually be there. So that's really, really, really important. And the other reason that one of the other reasons it's the global method is because it's the first time we have the full range of behavior. You know what that means? It means if you were lucky in the past, you would have gotten asked about a suicide attempt and you would have missed the person who collected the pills, who wrote the note, who bought the gun, right? You know that just that one of those behaviors, an interrupted attempt when somebody gets pulled off the ledge, do you know that's 4 times as predictive as an actual suicide attempt? And even more importantly, all those other behaviors that we weren't asking about before represent 87% of serious suicidal behaviors that patients or people engage in. What that means is in the United States, if we weren't doing the Columbia, we would miss 9 million behaviors a year. And just one question, intent to act, which is one of the game changer questions. It's number 4. When you have these thoughts, do you have some intention to act on them? Risk goes up 1,400% as an example. And you know, when we start to universally screen, you'll see all the outcomes, but it's led to improved mental health follow-up and treatment engagement. It leads to increase to voluntary hospitalization, lots and lots and lots of really important benefits and important harms that are prevented. Do you know what happens when you bring somebody to the hospital or they get an intervention that they don't need? It actually shuts them down from treatment when they do need it. You know, and when people, this is out of a policy document in Connecticut, they legislate in schools, and they say, right, that these kids are sitting in ERs for hours and hours who don't need to be sitting there in the first place, who are not actually at imminent risk, right? So we're reducing harm by identifying the right people who are actually at imminent risk for the first time in our history of doing this. And it's across all ages. Do you know what? 6 to 12-year-olds had the same odds of being high risk on the Columbia as 13 to 17-year-olds. So we need to do this routinely all the time in all these places. And what we know, as I said, most people never get to the doctor. There was a really important study, 67 studies, biggest meta-analysis. You know what it found? The majority of people who die by suicide never get close to a doctor. So the Department of Defense were the first ones to recognize that. They said, we have to put the Columbia in all hands. So the Marines tested that. Legal assistants, financial aid counselors, chaplains, you know, they lowered suicide 22% that year. And also a reduction in domestic violence, alcohol, you know, incidents and sexual assault. And that's what communities all over the world are modeling. And everyone in this building has a role to play. I want to tell you a story. I was in Connecticut giving a talk for the state, and this huge system said, you know, we gave it to the custodial staff. And this clinician from the VA said, exactly right. I'll never forget that case where the only person that veteran spoke to was the janitor, right? And it doesn't mean that janitor is going to ask everybody like you want to do in other places, but if it would be helpful, he'll be prepared to. I was at Jackson Memorial, this huge system in Florida, and they told me a story. The engineer fixing the light bulb in the patient's room, she started talking to him. He knew Columbia. She got the care she needed. And it's really empowering when everybody in the building and in the community is part of the solution. I don't know if you've ever heard of Kevin Hines, who survived jumping off the Golden Gate Bridge. That's fatal 99% of the time. And you know what? He tells a story that he woke up at age 19 and said, if just one person asks me if I'm okay, I won't do it. Gets on the bus to the Golden Gate Bridge, crying profusely, shoot off the bus, goes to the side of the bridge. And finally, this woman walks towards him and he becomes hopeful. And she says, can you take my picture? Forgive my horrible German accent. But 4 times she asked him. And he said, well, screw this. Nobody cares. And he jumped. And as he jumped, he realized that all of the problems in his life were fixable, except the fact that he just jumped. And he said, people considering suicide want someone to save them. What we need is a culture where no one is afraid to ask. And by the way, he gets down in the water and realizes he's alive and feels something slimy. Says, oh my gosh, I just survived jumping off the Golden Gate Bridge and now I'm going to get eaten by a shark. Just my luck. So he's on a show a few months later and this guy calls in and says, hey, buddy, it wasn't a shark. It was a sea lion that kept him afloat. So we know that's really important. And we know, we're here to talk about workforce prevention. And I want to tell you that spouses and family members are one of the most vital things we can do on the front lines. Right? Because, I'm going to show you about 80% of people, kids, parents, police, whoever it is that take their lives, do it in their homes, right? So you have those cards out there, ask your spouse, care for your spouse, et cetera. And NYPD has their own Columbia app that they're about to have, right? It asks if they're a family member, and then family members get connected there. And, I want to, you see down here, so this will resonate with everybody. This happens to be New York City firefighters. Almost 70% of them prefer to go to a spouse rather than using department resources. And we know also that the coworkers are uniquely positioned to identify risk. And the science tells us when you're helping a peer, it's the most powerful thing you can do when it comes to prevention. And the science tells us it increases hope, self-care, access to care, et cetera. And it's also a way to connect. Asking these questions is a way to connect. And the CDC tells us that connectedness is one of the most important things we want to do to prevent suicide. And lest you doubt the meaning of that, do you know there was a study showing its opposite, loneliness, was equivalent to smoking 15 cigarettes a day, more lethal than heart disease or obesity. And again, using this helps normalize the conversation, reduces stigma, and promotes help seeking. So I told you that, most people who die by suicide do it in their homes. So we need to leverage technology with the app, which you can all download. This is how it works. Everybody has a role to play. Are you using this to help yourself or someone else? Because it can be a self-check as well as a peer check. Are you under 18? Are you a veteran? Are you helping a veteran or a family member of a veteran? It goes through the questions, and then it connects you to a local resource based on geolocation, right? So if you're in this building and you're under 18, it would connect you to the closest youth. If you're a veteran, it will connect you to the closest VA resource. And just bringing this point home, this is Colorado, but every state, this is Colorado 10 to 18, but every state is the same across ages. You can see 8% end their life at home, 5% on the street, 5% in the natural area. I'm told that you would see the Columbia on the ledge of the Grand Canyon, but if you pay attention to this data, there shouldn't be a home, there shouldn't be a street, there shouldn't be a beach, right, where you don't see this. Like, remember, you would not walk into a bathroom and not see a sign, don't forget to wash your hands. So that's really what we're getting towards. And Pennsylvania was the first one to customize the app. And they said, I can't overstate the importance of this data. CDC data lags 3 years, right? Here we have real-time information that can inform our prevention efforts. This is an example. You see more Columbias in rural zip codes. That's what we want to see, because that was a barrier to detection. And really very exciting. We're here to talk about workforce and families. Many of us have, elderly parents or colleagues, right? So, and actually the highest suicide rate, the biggest problem that's increasing is over 85. And look at this, we say reaching the unreachable. We've trained tens and tens and tens of thousands of American Legion, men, 190, et cetera, doable, feasible, safe, and really empowering. And the underserved, it's in Braille and American Sign Language, et cetera. And really just bringing the point home in terms of how it helps you do your job, right? And helps care for citizens and patients. Look at this. Reduces ED recidivism, high risk decreases, hospitalizations decrease, readmissions decrease. A state saved millions of dollars in reducing unnecessary hospital days, but it's not about the millions of dollars. It's about the fact of the harm it does when you intervene in those ways. And this is all over the world that this is happening. And again, what that means, you know what we're dealing with in terms of resources in the state, in first responders. And you see this, FDNY, EMS, life-threatening increases number of emergencies with no budget increase, because only 1% of people get a high-risk answer on the Columbia. So that's why it's able to redirect all these resources in this very dramatic way. And what were those barriers? We didn't know what questions to ask. We didn't know what to do with the answers. We didn't know if it would cause harm. It's actually the opposite. It's actually it's relieving. It reduces distress. When people are suffering, they want to be asked, okay? But what was the really, really big one? Liability. So we don't have a perfect formula. We may never have one. People said, how can I ask? Malpractice attorneys have been writing about the Columbia for many, many years, saying because it has more science than we've ever seen in the history of doing this, 600 studies, 50 predictive, 9,000 if you Google Scholar. And the icing on the science cake is a study out of the Swedish ERs. Do you know it predicted death by suicide? That's never, ever happened in the field before. So you don't get into trouble for a bad outcome. You get into trouble for not doing something. So it's minimum standard of care. And I always say my favorite thing in the world is that when MIT had a suicide, like every university does, do you know the Supreme Court brief wrote about the Columbia Protocol as the reasonable standard with the 1% high risk answers? Why is that so exciting? Because now the roommate, the teacher, the janitor can ask without that barrier of liability. And the non-mental health providers of the Navy said it also helps with that internal liability. At least you knew you did everything that you could. And so, basically, asking can be the antidote to stigma and shame. It helps vulnerability transform into strength. It builds connectedness, and at one point in history, learning to wash hands began saving lives. And now we can really do the same thing with this tool. And I want to say, I said it's policy across the continuum of care, et cetera. But New York State was the first one to say this should be part of everyday life for every New Yorker. So in Department of Veteran Services, every state agency, so it's going to be at DMVs, transportation, right? Upstream, full-on public health detection. So that's what I wanted to share with you today. And thank you very much.
All right, thanks a lot, Kelly. So up next, many of you know Dana Moore through her job as directing the recreation therapy on the units for our inpatients, and also she's a union representative for many of you, and she works for all of us and with all of us on the EAP, the Employee Assistance Program, as the EAP coordinator. So here to talk to you about our EAP is Dana Moore.
Good morning, everyone. I promise I will be brief. I am here to talk about the employee assistance program. So as Marshall said, my name is Dana Moore. I am one of the members of the EAP, Employee Assistance Program Committee, as well as the EAP coordinator. Our EAP committee is a group of employees representing all agencies, New York State, RFMH, and Columbia, who volunteer to come together to plan health and wellness events for all of the NISP employees. We do have a referral and assessment service for anyone that's experiencing difficulties. They can always reach out to extension 8299, or they can send a general inquiry to the email on the screen, eapinquiries@nisp.columbia.edu. We do have an employee fitness center that is located inside of our patient gym. for employees to access for your own health and wellness. So if anyone is interested in using the Employee Fitness Center, please contact Claudia Rockman at extension 8450. It is important to know that the fitness center is for employees and the gym is primarily for our patients. So we do like to make that distinction as well. We do plan and offer additional services and events that some of you have either heard about or joined. One of them just passed is your Bring Your Daughter and Sons to Work Day, where children of our NISP employees do come in and visit various departments within the facility. Here you can see them visiting the lab, the brain lab, and the safety and engineering. So it's an event that is one of our biggest successes, and the children do enjoy themselves. We do have plum benefits available for all employees. This is just a program that provides leisure benefits for all employees to take advantage of. If you are interested in getting your plum benefits on the list, please contact again Claudia Rockman at extension 8450. Some of you have seen in your emails, we do have a newsletter. It's called the Frontline Employee. It is a short one-pager that we send out on a monthly basis, just to give you some insight and ideas of how to navigate different life situations. We also provide or host lunchtime seminars. We have people come in from different agencies like Sony Ma State of New York Mortgage Agency, who will come and talk to each of you about mortgages, what that looks like, how you qualify, who qualifies. We've had some arts and crafts events like aromatherapy. We do a big event for Christmas. And just yesterday, if anyone was able to stop by our swap and shop that happened yesterday in Kolb Lounge, we do that twice a year as well. So please come out and take advantage of some of the lunchtime seminars that we have. They're all for you. And just a plug, we will be having our annual health fair on June 26th, again in the Kolb Lounge. So most of these vendors will be here to support health, wellness, and work-life balance information for you. So the Employee Assistance Program is here to make your life less complicated. So please reach out should you need our assistance with anything.
Thank you, Dana. We are recruiting people for our Responding to Traumatic Events in the Workplace team. Our RTW team assists other employees when they're in crisis. And I know that we do this a lot for each other on our own, but the facility wants to make sure this is happening on all shifts. So we're always looking for more volunteers to help other employees. And this could involve referral information, accompanying them to a medical facility or treatment, giving them a ride home after a trauma. And the traumas could be, loss of a loved one or anything traumatic at work or a health crisis at work. It could be that they need somebody to help them fill out the accident or incident report, and a lot of different ways that you could help your fellow employee. And again, I realize that we do this on our own. But we want to have a team to make sure that those things are happening for one another. So anybody interested in joining the RTW team can contact us at staff development. And then we would have you take the RTW class, and you would also take psychological first aid. Now, with psychological first aid, you could also become a member of a team that would respond to emergencies statewide for the Office of Mental Health. The Office of Mental Health is recruiting people to be on the list to respond to emergencies, and they could be like plane crashes or major accidents, other things like that. So if you take that psychological first aid class and you take a disaster mental health course, you could be on that list to respond to statewide and sometimes even national emergencies where they would need a lot of mental health professionals. But again, those trainings are available to anyone that wants it. For the psychological first aid, anyone can take those. But the disaster mental health training, they would like it to be professional social workers, nurses, doctors, so that they, could have them to respond to those, statewide or national emergencies. I'm going to talk to you a little bit about ligature risk and suicide prevention here at NISBE. I know that Dr. Posner talked to you about suicide prevention, broadly for the work that we do here for the community at large, even the international community. But here at the Institute, we know that inpatient suicides, when completed, like 75% of them are done through ligatures. So it's our responsibility to reduce and eliminate ligatures in the hospital. And, one of the ways of doing it might be swapping these metal poles out for plastic ones that you can't loop anything through. And we identified some risk in the bedrooms, bathrooms, public bathrooms, hallways, and day rooms. And some of the ways that we mitigate these risks are to have patients on one-to-one if they are at high risk, and also having continuous patient checks throughout the unit. And they have cameras as well, monitoring some of the more public high-risk areas. When a patients are discharged, the 90-day after discharge, there's a high risk for suicide as well. So one of the resources that Dr. Posner showed that would come up on the app, but also that anybody could use and add to their safety plan. And we encourage all of you working with patients, outpatients or inpatients that are at risk, to add the 988 number to your safety plan. It's, anyone can call, text, or chat 24/7. And it could be suicidal, or they could be experiencing a mental health or substance use related crisis. And the 988 number could help. So again, that's 24/7. People can, chat or text, and, it's there for all of us. So, we really encourage all behavioral health professionals to utilize that number. So, we're going to review some of the PDFs we sent out. We go over them every year, I know, and we're responsible for understanding what they contain. And the PDFs are always available for your reference and review through those emails that we send out. They're on Insight, and you can request them from us at any time. And many of you in clinical areas have also seen videos about updating policies. And those are still available and will still be available on Insight. And, we'll let you know if there are more of those. But, here today, we're going to go over a couple of the general policies. And, one that we always like to go over every year is the respect policy. And so in the respect policy, it says, to look upon or interact with esteem or honor, expressing consideration and courtesy, the active demonstration of relating to others with regard and consideration for their feelings, rights, and differences. And consideration is described as thoughtful attention, and civility is courtesy and politeness towards other human beings. And all employees, any title, should maintain a polite and respectful demeanor with all individuals, whether patients, visitors, coworkers, collaterals, etc., while representing NISBE. Respectful and courteous behavior should be evidenced in all work-related interactions and communications. And then the employee-patient relation, PC 527, keeping appropriate boundaries as a helping professional. So we shouldn't borrow money or valuables from patients, encourage or condone any illegal behavior with patients, or of course engage in intimate relationships. And if you had a relationship with a person, it could be, this was my landlord's daughter previously, like 7 years ago. The team could, if you had a business relationship or personal or intimate relationship, you would discuss it with the team before interactions with that person. Or, if you had it, then afterwards you would have to say, but do try to talk to your team immediately if you had a previous intimate or business relationship with an individual that comes into care. So they can decide whether or not it's appropriate for you to give service, but it's better that they find out before as opposed to afterwards. And then once we're serving them, of course, we're here to help them, not exploit them. So we want to do our best to make sure that they're getting the care that they need. So Medicaid PDF is required for everyone. And I know that we're not, we're a research facility. So even on the research inpatient units, we don't bill for Medicaid. In the outpatient clinics, they do. And I think on one of the inpatient units, they may. So, I always ask for you to look at this as program oversight. Whatever your oversight agency is, whether it's NIMH or any OASIS or whoever your oversight agency is, kind of look at it in that way. And that if you're making a mistake, you want to correct it right away. You don't want it to be seen as inefficiency or that you're intentionally bending the rules. So work with your oversight agencies just like you would with Medicaid, and do your best to make sure that you're correcting any mistakes that have been made. Right away, and working with your team and being close with your liaisons from your oversight agencies. Language access. So we want everybody to know what to do if they encounter somebody that speaks in a different language. We have I Speak cards. We're putting new ones up too by the safety desk and the elevators. And we also have telephone interpretation. And the safety team knows, how to get the telephone interpreter on the line. The staff on the units know how to use the telephone interpreter. And if anybody has any questions, it's a number that you call, and then it's a code, and it's really easy. So anybody that needs an interpreter should be able to access it. We also have video remote interpreting, and of course for sign language that would be great. And you could use it for any other language as well, where on an iPad or your phone, you can get an interpreter for any language or sign language. So we have access to a lot of language services here. You can send documents to me to be translated if you need them to be. And we want all employees to know that and understand that we can serve the public in all languages. Okay. So any language that we need, and if we, run into barriers, we'll do everything that we can to get around those to make sure that we can provide quality service to everyone. So, and if anyone has any questions, they can always contact me, and I can let them know more about our language services. Reasonable accommodations. We have to do that both for the public and for ourselves. So we have the right to request accommodations. It could be a standing desk or a computer face that has a larger numbers. Whatever it is that you need to make accommodations for you to do your work, you can request from your supervisor. You have the right to do that. But with that being said, we also have a responsibility to the public to provide reasonable accommodations, for anything that they need. And if you have questions about that, I would suggest contacting your HR. Your respective HR. You can speak with your supervisor about it. And if your supervisor has questions, then you can contact the HR. Gender-based identity in the workplace PDF was sent out. And, everybody has the right to confidentiality. So you shouldn't be disclosing someone's gender preference for them. It's up to them to disclose that. And also, the OMH has asked that all single bathrooms be non-binary bathrooms for us. And, those are our two big takeaways from that PDF. But you could read, more. Again, those PDFs are on Insight. They were sent out to you. And if you need them at any time, you can request them from us. For records management, their OMH has a records officer. So if you have questions about any data stages, whether it's creating, active use, and active disposition, data bins for disposing are by the service elevators here in the parties building. I think there's one on the second floor. But if you need a large data bin to shred data that you're getting rid of that's sensitive, you can talk to housekeeping, and they'll help arrange for that. They work with the people that pick up those bins and store them. And those are locked bins that you can drop, packets of information into if you have sensitive information that needs to be shredded. And of course, emails are considered records. So, do your best to protect those, make sure they're encrypted. I think Chris Stanley is going to talk to you a little bit more about that later. And we have to provide the consumers their records most of the time. So when they request records, you need a safe way to make sure that they get their records, or, their providers that are requesting the records, that they're giving us permission to send it to, that they're getting that. So work with your team and the records office manager in order to make sure that you're doing those things safely. Okay, and any questions, you can contact Psychiatry. Again, Chris Stanley will go in depth into that a little bit more, but that is the records management PDF. And the internal controls PDF talks about controlling the work environment, risk assessments, control activities, can be directive, preventive, and detective. Like the cameras are both preventive and detective at the same time. Information and communication through meetings, emails, communications, signs, monitoring risks through supervision, case reviews, internal and external audits. So these are some of the ways that we work together to help make sure that we have a safer environment. Organ and tissue donation. Most of the time, we don't call time of death here. In CPR, we tell people if somebody goes into full arrest, they should continue compressions until EMS shows up. So, but it is, if it did happen, and it is a requirement of any hospital where somebody could die, that they call the organ procurement organization. And the OPO here is Live On New York. The designated, and they're the designated regional OPO. And the number is up here. If anybody has any questions or needs that number at any point in time, they can always contact administration or myself. But, the hospital is going to let the next of kin know. So if you're working with the medical consenter or the next of kin and somebody does pass away, the OPO will contact them, because the hospital is going to let them know. So, if they need help working through that, it's an important fact for us all to know that they might be working with the organ procurement organization. Okay, and next up is going to be Alicia Carreau, and most of you know her. She's been working with us for a long time through COVID. There, several years doing many different things, but she's our current infection control nurse and has been since 2016? Yeah, 6. Okay, all right. So, Alicia Carreau, yeah.
Hello. Okay. So hand hygiene, this is one of the most important things you can do to keep yourself and other people around you free from infection. And it's soap and water or the alcohol-based sanitizer. Soap and water, you wash your hands, it's 20 seconds. It's not just singing happy birthday anymore. It's probably twice you'd have to sing it. But please count next time you wash your hands. You'll see most people do not wash their hands long enough. And you need to use soap and water after toileting, before eating, if your hands are dirty, right? And the alcohol-based sanitizer, it's for you wipe until dry, and that's before and after patient contact and after removing gloves. I think some people forget about, if you're wearing gloves, as soon as you take off your gloves, you need to clean your hands. Flu vaccination, TB screening. So flu vaccination, the season just ended not too long ago. Generally, it's October through April, and I'll offer flu vaccinations to all workforce and to all patients. And when flu is considered prevalent by the Department of Health, then for those who are not vaccinated, they're required to wear a face mask. Many people have their vaccine over at Presbyterian or Student Health or the drugstore. If you receive your flu vaccination outside of PI, please send me a copy of your record so I can document that you are compliant with that. And then the TB screening questionnaire is an annual requirement for everyone. Everyone who started before you came in, before you were cleared to start working, had TB testing. That was either the two separate PPDs or the blood tests. Once you're here, the annual requirement is a screening questionnaire. That is required once a year. For those who haven't done it yet for this year in 2025, we'll have a reminder sent out in the fall when I send out notification about the flu clinics. And you can either do it on a paper copy or they'll be available through the Red Cap app. Universal precautions, PPE. So surgical face masks, you are always welcome to wear a surgical face mask. And we have masks throughout the building available. If it became mandatory, then notifications will be sent out and it'll be on the e-boards and through emails. The N95 masks are for staff taking care of a COVID positive patient, or if there was an outbreak on the unit, then at times it could be required where all staff, anyone entering the unit would need to be wearing an N95 mask. Gloves, whenever you have the possibility of coming into contact with blood or body fluids, you should be wearing gloves. With that, gloves do not replace hand hygiene. So please don't walk around in the hallways wearing gloves, okay? You can hit the elevator buttons, open the door handles, and clean your hands. But wear gloves if you have any risk of blood or body fluids or if you're cleaning and you would wear them. I'll jump down to Super Sani cloths. Those are the containers with the purple tops. When you use them, gloves are recommended because they're pretty strong to use. Goggles or face shields, if you're pipetting blood or any risk of having a splash to your eyes, use eye protection. We've had somebody pipetting and they pipetted the wrong way and it's got up, or even just pouring one into another tube and they dropped it and it splashed. So please wear eye protection if there's a risk. And I had mentioned the Super Sani cloths. So all high contact areas should be cleaned off. Equipment that comes in contact with patients or participants, like a blood pressure cuff, needs to be cleaned in between each use. There's something called a kill time. The product needs to remain wet for 2 minutes, and that's how you know it's effective. If it's not, you reapply it. We've had a norovirus outbreak on the unit. That's what's commonly known as that cruise ship GI virus. So people know if for norovirus, the Super Sani cloths and the alcohol-based sanitizers are not very effective. You use soap and water to clean your hands, and we would need the product that has either bleach or the hydrogen peroxide in it. Other than that, the Super Sani cloths are pretty great for clean off your desktop, clean off your keyboard, clean off your phone, because many of the equipment is shared by others. COVID, it's not gone. If you were to test positive, please contact me, either my name, email, or infection control, and contact your HR department. We still have a mandatory quarantine with a minimum of 5 days. And then after 5 days, it's based on improvement in symptoms. And for patient screening and testing for patients and participants coming into the inpatient units, we continue to require a negative PCR within 48 hours of admission. And then on day of admission, we do a series of 2 antigen, the rapid tests, and again, 48 hours later. Occupational exposures. So this is the needle stick. This is the splash of blood to your eye. This is the bite by a mouse. This is anything where you have the exposure of blood or body fluids into either your skin is open or your eyes or your mouth, your nose. So you want to immediately report this to your supervisor. Nobody should be ever working by themselves. So you should always have somebody with you to help make notifications if needed. So let your supervisor know you clean the affected area. Notify safety. 5100 is the main number to safety. Safety will contact me, or if it's off hours, there's a nurse on call at all times. They'll contact the nurse on call to help you. And we want you to either go to the emergency room or to your own healthcare provider. And very important to complete an accident report online. That's on Insight. And this will generate a workman's comp number. So you want to have that on file. And then if to go to the ER or somewhere else, you don't have a cost. You will not be paying for that. But even if you think, oh, it's something, it's not a big deal, you won't do anything, but then a week or 2 later, something, comes up from it, it's good to have this baseline that you reported it, you made an incident report, and you sought some medical treatment. So waste, our sharp containers are regulatory red bags and regular trash. Sharps containers, everything that's sharp goes in the sharp container. Of course, even needles that are not used go in the sharps container, because you're not somebody who's taking care of the trash would know whether they're clean or not. Anything, the blood tubes, cover slips, glass medication, anything that's sharp goes in the sharps container. Red bag, I think we've come a long way. People are no longer putting pizza boxes and soda cans in red bags, but there's a lot more going in red bags than needs to be. Red bag is for the pathological specimens, animal waste, carcasses, body. You'll if you work in that research department, you'll have training on how to dispose of that. But in the clinical areas, soaked, caked, dripping with blood. Okay, so that's what goes in a red bag. So you draw somebody's blood, and you have a few drops of blood on the Band-Aid or on the 2x2 gauze. You're using gloves to draw blood. That all goes in regular trash. Even as you see, it's urine, fecal, diapers, all go in regular trash. Okay. So unless, almost if you think of for the red bag, if it would leave a puddle or a fluid at the bottom of the bag, it's released somehow, then that needs to be in the red bag. Otherwise, it's regular trash. And that I have written there. So perform hand hygiene well and often. Get vaccinated against the flu in the fall. We're in a hospital. It really is the standard of care. Complete your annual TB screening. Remember, it's a questionnaire. It's no more TB testing. Use your PPE correctly. Clean your equipment. Clean your areas with those super sani cloths. If you were to test positive, please contact me and your HR department. Act immediately if you have an accident or exposure. People don't get in trouble if there's an accident exposure. There are usually things we can learn from, of maybe different equipment or different techniques that need to be used. And dispose of your sharps and trash properly. Thank you. Okay, Chief.
All right. Hello, everyone. My name is Shavina Job, and I am the Chief of the Safety and Security Department here at New York State Psychiatric Institute. So I'm going to give a quick annual update on safety, fire safety, emergency management, and security. Just so everyone knows, I've been avoiding this annual update for the last 2 years. Chief would call out every for the last 2 years, he called out on the day of the annual update. And I'm like, why are you calling out? Why do you want me to do it? That's your job. Not knowing that he was preparing me for one day to take over his job. So here I am now doing the annual update. So some of you may know me, some of you don't know me. If I haven't had the chance to meet you yet, but you do need to contact me for any reason, my email is shavina.job@nyspi.columbia.edu. My office extension is 8506. If you can't reach me there, you can always leave a message for me at extension 5100, which is the non-emergency safety number in case you need to contact me. So a lot of our forms that you guys come down to the safety desk for are now available on Insight. We also post the policies and procedures, any psych emergencies, any medical emergencies, any cardiac emergencies. All the emergency numbers are also listed on there. Accident for employees and non-employee accident reporting forms, our work order request forms, our safety data sheets are all available on Insight. If you have problems accessing any of these forms, or you need us to help you fill out the forms, you can always come down. We have hard copies of every form available at the safety desk. So the most common form that we do use in safety is our badge request form. And just a reminder that this form has been updated in the last year. A lot of you are still using the old forms, and I know because it does not have this information at the bottom of the form. A PDF version of the form is now available on Insight. You fill out that form, you submit the completed form along with a photo ID of yourself to this email here. This process has changed. In the past, we would give out the badge request form at the desk. You would go into the ID room and you would have your photo taken. It's no longer done that way. It is a contactless process now. The other process that changed is our volunteer badge request process. So volunteers now, we're no longer accepting volunteer ID forms at the safety desk. All volunteer forms have to be submitted through the HERO system. And if you guys need help or you're not sure how to use that system, that you can always reference this slide here, volunteer services, their extension, their email, and they'll be able to help you guys with those forms. But for volunteers, all volunteer ID forms have to be submitted through the HERO system. All right, so just a little bit on fire safety. Everyone know in the case of a fire emergency, you see any signs of fire, you smell any smoke, you smell burning, you want to always report it to safety immediately at extension 5555. So I did do building rounds this year in preparation for a joint commission, and I noticed that a lot of people do use extension cords in their offices. Just a reminder, you should not be using extension cords unless it was approved by our engineering department. If you do need additional outlets, you can reach out to them, or you can be issued a facility approved extension cord by the engineering department. So we all know the acronym, or we should know the acronym RACE, which is Rescue, Alarm, Confine, Evacuate. If there is a fire emergency, you want to get everyone out of danger. You want to pull the pull station. You want to notify safety immediately, step out of your offices, close your doors, and just await instructions from us on if you need to evacuate or not. All right, so this is the reason why we do these quarterly fire drills. I know sometimes the drills can be a little annoying because they are unannounced. Sometimes you're in the middle of a meeting. Sometimes you're with patients. Sometimes you're just working and you don't want to stop what you're doing to participate. But it is important that everyone participate in our fire drills because we are training you guys every time on how to use the pull station so that you know where they are. Reminding you to always call safety immediately to report the fire. Step out of your offices, close your doors, where your nearest exits are, how and where to line up, how to use the fire extinguishers. All of that is being taught to you in the quarterly fire drills. So we are still using the visitor management system in safety. At one point, we were using logbooks, where our visitors would enter the facility, they would sign in, they'll put where they're going. We had a lot of issues with that system because a lot of the handwriting wasn't legible. We had to trace, we had to do an investigation. This system has made it a lot easier for us to scan people's IDs, input their information, have a photo of them, know where they're going. So it's actually a safer system for everyone. So we are still using that system. Just another reminder that when you're in your offices, if you are going to step out, you want to step out. You don't want to leave your office doors open and unattended. You want to secure all your valuables in the safe. And if you do experience any type of theft or something missing from your department, your office, just try to notify us right away because it's easier for us to investigate the situation. All right, last year, I know we spoke about a system that we were trying out, which was the IRIS system. Initially, this system was designed, it was purchased to be used for psychiatric and medical emergencies. But after a few trials and errors, we realized that the system wasn't quick enough or it was too tedious to use in the case of an emergency, and the traditional way, response way was better. So now IRIS is just used to send out alerts for emergency situations, whether it's weather alerts, major construction being done in the building. That's what we now use IRIS for. And just a reminder to everyone that our emergency number is 5555. Try not to block up our emergency number in the case of a non-emergency. We like to keep that line clear and free. In the case where someone does need to contact us, they can always contact us. But if you do have any issue and you need to reach out to safety. Our non-emergency number is 5100. I know a lot of people remember this number, but tend to not remember this one. So if you do need to call safety, non-emergency, extension 5100. All right. Thank you.
Good morning. I am, as the slide says, Chris Stanley. I'm the Director of Cyber Strategy Risk, HIPAA Security Official for OMH, and more importantly for today, our IT Director here at NISP. So glad to be here and give a really brief overview of information security principles. Among the PDFs that Marshall mentioned that you got, there are several that cover these topics. I am certainly not going to try and cover all of that in the couple minutes that I have here. So certainly there's a lot that hits the news that's flashy: internet crime, nation state actors, all these sorts of nasty bad things. And we in Central IT, NYP, Columbia, New York State, we work to help prevent all of those things. But the reality is that 88% of breaches that occur are because each and every one of us make mistakes throughout the day, right? So human error creates issues. What I want to talk about today is just ways that we can each minimize risks to our own information, risks to institutional information as well. So again, policies, procedures, these exist. They can feel annoying. They actually exist for a reason. So certainly try not to be bypassing those just out of personal convenience. We get it. But even Josh, as he's recently spoken about some of the organizational restructures and things like that, right? The focus is on respecting our peers and acknowledging that we need to work together, and sometimes the needs of the collective might outweigh our short-term needs. So that certainly falls in line with this principle. Breaking it down just a little bit, there's some really basic things like not connecting your computers, mobile devices, whatnot, to more than one place at a time, right? Not bypassing network firewalls, having your computer connected to the wired network and then turning on a hotspot on your phone and connecting wirelessly. You're bypassing all of the network security that we have in place when you do things like that. Patching our systems is really important. And again, at an overall perspective, right, the general computers that are issued and maintained by Psychiatry, we patch those for you, right? But, certainly equipment gets older. There might be dedicated equipment. If you can't patch it, it really shouldn't exist on the network and needs to be isolated. Sometimes that's like specialized equipment, right? The $1 million microscopes that run on really old operating systems, they live on separate isolated networks. The HVAC system, right? We can't maintain that in the same way that we would a regular Windows computer. It's on a dedicated network. Can certainly work with SciIT on that. In other cases, it's that we've invested in equipment, and the equipment lasts a really long time. Like Apple does a really good job making hardware that lasts way longer than they actually support their operating system. So we have to plan for equipment being replaced and upgraded. And again, that's personal as well as institute equipment. From a individual files level, right? We all receive maybe Excel or Word documents in mail now and again, right? And we'll sometimes get prompted to enable a macro or update links. Our default answer for those sorts of things, unless we're 100% sure we know what's going on behind the scenes there, should be no, because those sorts of things are the ways that those bad actors do gain access to all your files and potentially all of the Institute's information. Not adding extra software, plugins in your browser, add-ons, those sorts of things will also really help protect you as well as protecting all of us. So remote access, a little bit similar to the first bullet, right? So, we've got all sorts of remote access options available that should cover every possible need that you might have. We maintain the network in a relatively open environment, recognizing the diversity of the research that we do, right? We try and not put excessive constraint on folks. That means that there are bad things that people can do, right? Ways that people can bypass some of our systems because we don't want to be excessive in blocking. But again, leverage the provided remote access solutions. Don't, start your own Guard or PC, go to mypc.com or whatever solutions, because again, that creates exposure for you as well as the Institute. Back to the idea of patching and software updates. Patches generally do require a reboot. I hate rebooting my computer too, because I have 500 windows open that I'm doing all sorts of things. But until you reboot your machine, those services aren't restarted. The patches aren't really fully applied, right? So make sure that you're rebooting at least monthly. And generally speaking, we enforce that for you, whether you like it or not. So do it at a time that is most convenient for you, or it will happen anyway. Browsers at this point are a really common way for bad stuff to happen to your data and your computer. So restarting those, the general advice at this point is about weekly. Most browsers at this point are applying automatic updates in the background. So you may see little icons saying, hey, restart. And in fact, if it does that and you restart, it'll even generally maintain your sessions and stuff. So it's really, like a 15-second inconvenience, and then you're still logged into everything and whatnot. So definitely follow through on that. No talk on information security would be complete without discussing passwords. I hate passwords too, but they are a necessary evil for many of our systems. Obviously, any default password that might be compromised gets known by someone else. Change it immediately, and use strong passwords. The graphic here, while a little suspect since it's an industry sponsored, they want to sell us stuff. But whatever, it's designed to highlight that the stronger and longer your password is, the harder it is for bad guys to break into that password, randomly guess it in what's called brute forcing your password. So that's why the password policies exist. At this point, they're long and strong, but you get to keep them for a year. So that's kind of nice. Because according to this, it should take 300 billion years to break your password. So I don't know that that's true, modern computing, but you get the idea. That said, password brute forcing, in part because of this reality, is not the primary way that folks are stealing credentials. Generally, there's lots of places on the internet where password databases get stolen just because of bad system administration and things like that. I'm sure you've all heard news stories of that. Because of that, we highly recommend that you use a unique password and passphrase, basically for each different organization where you maintain an account, right? That way, when a password, not if, but when a password gets compromised from one location, it only impacts that location. It's not impacting all your other stuff. The obvious pushback on that is now you've got dozens, maybe hundreds of different passwords that you have to keep track of. Again, I'm right there with you. Leveraging password managers. There are a number of really good ones that will encrypt the information before it saves it to the hard drive or loads it into a cloud environment. KeePass and Dashlane are two that we highly recommend. If you're, in a personal setting, more modestly, the operating system-based password managers generally work pretty well within the confines of those environments. So. Modern applications are really moving towards getting rid of passwords altogether with technology called passkeys. As you see that start to pop up in some of your newer systems, applications, absolutely. It's a great technology. It's really replacing user IDs and passwords. it is sort of cutting edge. So you're not seeing a ton of it quite yet, but as you do, those are good. For all the rest of us in the normal world, using multi-factor authentication, MFA, really should be your de facto standard. There's no reason not to do it for any internet-facing system at this point. Again, those technologies are pretty mainstream at this point. Things like Google Authenticator even, are very easy to leverage. So, with all of this and managing our information, it's important to know what our information is, right, and how sensitive it is. So knowing and classifying our data is our responsibility. It's one of the requirements that we have as we work with data. And it's interesting. I'm amazed, how often folks might justify, let's call it cavalier activities by saying, "Well, it's not PHI. Like animal researchers, I care about you too. Like your stuff matters. Intellectual property that we might have, our financial data, those sorts of things, right? It's all worth protecting." So, certainly the measures might be slightly different depending on the criticality. Things like internal engineering diagrams could be sensitive from a safety perspective, right? And then sort of just barely, important would be things like internal org charts and whatnot, right? Like, sure, we've all got access to those, right? Like we share those relatively broadly, but they're not public, right? And potentially they could be used for things like phishing and whatnot, right? So again, taking some reasonable precautions depending on the scope of the data or the classification of the data defines sort of what reasonable means in any particular case. Obvious corollary to that, then, only use secure systems for anything that's not private, right? So again, this isn't just PHI, right? We provide support for things like Google and Dropbox, but they're not compliant for internal and confidential information, right? They're designed for really a quick collaborative, near public sort of scenario. Likewise, things like Git and Slack, fantastic tools, right? But again, for things that are in more of the public domain, those organizations will do their best to try and protect your information, but they're under no real obligation to do so. And then finally, generative AI is really all the rave these days, but does introduce a lot of privacy concerns. And as a result, New York State policy at this point more or less prohibits it for anything of an internal nature. So you can check out the details of the policy. I'm not going to go into it. We do work closely with New York State has a AI governance board that we work with. They've recently brought in basically an AI czar who's really got some good vision for how to make this work. And of course, we've been doing AI in the machine learning side of the world for many years here, right? And just acknowledging sort of how that works in the newer world. It is all important, but we do need to be, again, mindful of the classification of our data, where that might be shared, what might happen with the information that we enter into, the chat GPTs of the world, and whether that information sort of becomes part of the public training data. So when we do then use secure systems, things like Teams or file shares or RedCap, that's great. That's where sensitive data should live. But we do need to make sure that we're paying attention to who has access, reviewing that periodically, looking at who has access to our RedCap projects and members of our Microsoft Teams environments and things like that. So, and then finally, more at the ad hoc level, encryption of files. If anyone's still using removable media, paying attention to encryption of the storage, even encryption of email. There's ways to make email conversations, sort of encrypted. So a lot of that information is on Insight, and again, Insight IT, we're happy to help guide on that. So again, there's way more information on all of this in the PDFs, both the InfoSec and HIPAA PDFs that Marshall is sharing. In addition, there's a couple specifics trainings coming this summer. HRPP will be running a training mid-July on data privacy and sharing. And then later in the summer, there should be one specific on HIPAA coming up probably in August, be my guess. In addition, certainly visit the CIT section of Insight for all sorts of policies, information, tools, etc. And then, from a personal, I always like to throw a personal one out here as well. There's a federal organization called CISA that has a really nice section of their site called Securing Our World. It gives all sorts of nice personal tips on how to manage information security in your own personal life. So any questions, certainly reach out to us at CIT. And with that, I'm going to hand it over to Matthias.
Good morning, everybody. I'm Matthias Quick. I'm the Right to Know officer for the Institute, and I'm here to talk about the Right to Know law. But before I do, I just want to give you some background, because over the last couple of years, I had a couple of questions and people are asking what's the context of the Right to Know law. So the Right to Know law was introduced in 1986 as the Emergency Planning and Community Right to Know Act. This came along with the Pollution Prevention Act, which was introduced in 1990, also with the Resource Conservation and Recovery Act, or RCRA, of 1976. All these things had one thing in common: to protect public health and the environment by ensuring that communities are informed about the toxic chemicals being released into the air, land, and water by manufacturing facilities. That's basically us. Every institution, every institute, every company is considered a manufacturing facility. This was then paired with the OSHA Hazard Communication Standard. They focus on work safety. And there's also the New York State Part 820 of Code Rules and Regulations, which is specific for the Right to Know law. And there's also the New York State labor law, which covers right to know. But what I want to talk to you about in the first place is the RCRA Act. RCRA is regulated by the Code of Federal Regulations, or CFR, Title 40, and you can see in this chapter section, there's the air program, water program, pesticide, radiation. But what's most important for us is the solid waste. So basically everything that's going out here as a waste is considered a solid waste and could be considered a hazardous waste. Just to give you some information, this is more detailed than you need, but what's important here is solid waste, which are not hazardous wastes, are those that come from households. So basically everything you produce at home is considered non-hazardous by definition. So if you have a bottle of unused vodka or something, which is ethanol, you can dump it in your sink. You cannot do this here, because here everything that goes down is considered a hazardous material. And ethanol, as you know, is flammable, and so far is a hazardous material. So do not bring anything from home to here and think it's easy to dispose it of in the institute or to the other way. It's not allowed. So there are clear regulations, and the goals are basically protect human health and the environment, conserve valuable resources, and there's a cradle-to-grave principle, which means once you have something here on site, you make it as a waste, you declare it as a waste, it's your responsibility for all time to come. There are a couple of groups. There's a generator group, there's a transporter group, and there's a treatment, storage, and disposal facility. But let's just focus on the generator and transporter part. Usually for the generator, you see these people in hazmat suits that produce a lot of hazardous waste. In reality, it's anybody in the institute, like a lab researcher working with some samples, produces waste which is considered hazardous waste, depending on the type of waste. As I just mentioned before, if you take any sample from a lab, and the line is very thin here, it's not just a waste. Any material that's hazardous, you cannot transport this, because then you have to have a transport authorization by the Department of Transportation. If you don't have this, there are fines. So per person, there's 121 fine per day per incident. So if you take one sample out, this is one fine. If you have, for example, a waste container open, it doesn't have a label, there are 2 incidents, and per day there's a fine of $121. If you basically transport something in the subway, this makes it a criminal issue. So, and there is a fine for $50,000 and imprisonment, and the institution also has to pay $1 million. And I think in the current environment, everybody loves to pay extra money. So be considerate about this. But let's go back to the right to know. the rules that we have to fulfill is basically the employer, NISP, has to make sure that everybody knows who the right to know officer is. There's posting in the elevator. I just mentioned the name of the right to know officer, which happens to be my name. There's annual training, which you're just taking right now. I have to maintain exposure records, and also I have to provide safety data sheets or SDS within 72 hours upon request. Just to make the point, if you ask me, what is this chemical, I have to give you the chemical information along with in form of the SDS. Do not ask me, 2 days ago, I was exposed to something that looks like this, or I have no idea what this is. I have no way of finding out what this actually was. So be aware of, if you have a question about a chemical you're potentially exposed to, ask immediately. That said, I also realized that many people don't have any idea what an SDS is or how it's organized. I'm not just talking about the lab folks, but it turns out many people in the lab have no idea what an SDS looks like. An SDS is basically it has 16 sections, and they give you information about the substance or the mixture of the supplier, hazard information, and what's most important, which comes up in the next part, is the third aid measure. So an SDS for a particular compound informs first responders and down the road responders about any potential hazards that are associated with this chemical. And then I have just listed a typical SDS. This is the front page of acetic acid. You can see who produced this, what is this compound, who to contact in case of emergency. There's a little disclaimer that basically says once you purchase this item, it's yours, which makes you the generator of waste if you dump it down the drain or dispose of it properly. It shows some information about the hazards associated with this. There are different categories. There are different display items that indicate what kind of hazard is associated. It's very easy. This is flammable and this is corrosive. And this is a typical lab chemical that most people find. And if you consider this is only for the lab folks, no. This is a housekeeping item, goof off. And if you look at the symbols here, they're pretty much the same. So do not think this is only for labs. This is for everybody here. So everybody is exposed to any kind of chemicals in the workplace. And for each chemical or for each compound, there has to be an SDS. If you have a question about this, as the right to know site in Insight states, you can ask me. I'm required to provide this SDS within 72 hours. However, in the case of an accident, this is way too long. I usually have these available immediately, but also if you need to go and find the SDS, you go on Insight. We have the lab SDSs, and we have housekeeping engineering facilities and kitchen SDSs. And what I just introduced yesterday is another section for construction. There are a couple of construction projects coming up. These SDSs will also be included here. So if you have any questions, you just check here. There is a general site for the SDSs for chemicals. You can go on ChemWatch, which is a service that's provided by the Institute. You can look up any chemical, you type in the name, the CAS number, any identifier, and you find the SDS. And then there's also a list of the SDSs that are of all the compounds present at NISP. As I just mentioned, I updated this yesterday. The other part that's important here for the ChemWatch database, ChemWatch gives you a general SDS for each compound. There is a change in the regulations which will take effect in January of next year. Each provider has to provide their individual SDS. So if you have sodium chloride, it's not sodium chloride for everybody. There's a Sigma sodium chloride. There's a Fisher sodium chloride. And we have to keep all individual SDSs. So there will be some communication coming out soon to make sure that we capture this. Hazard communication, this is the global harmonized system. Basically, worldwide, you find the same kind of symbols to inform you about the hazards. Where do you see these? Basically on our chemical waste labels. You can see the little pictograms here that match these. And then, as Alicia mentioned before, there's regulated medical waste, the regular red bag waste. And if you see this label here, this looks pretty much familiar to this one. So any regulated medical waste is a hazardous waste and has to be disposed of properly. There's a specific type of service provider that picks up our regulated medical waste. There's no place for pizza boxes. There is no place for gloves that have been used for any buffer preparation. This is really a hazardous material. So be aware that this waste to dispose of costs a lot of money. There's also, under the hazardous waste regulations, there's universal waste and used oil. So there's e-waste, old computers, oil, batteries, lamps. These all have to be collected and are basically managed under the same hazardous waste regulations as any of these. Then, if you want to be very smart and you think, why do I care? I just throw out this bread bag into a regular dumpster. This makes this entire dumpster hazardous. So any hazardous waste combined with regular waste makes the entire container as a hazardous waste. As I mentioned before, these are expensive. You can fit, I would say, 50 of these bags in the dumpster. So the dumpster price will be multiplied. I don't know the number. It's exponentially, basically. So do not do this. Keep your waste separate. If you have questions, ask before you do this. If you see something, say something. The same thing. Maybe not by calling any agencies, the EPA or the DEC. Come to me and we can figure this out. Short topic on the accident incident reports. There will be a special presentation using the same slide. I was aware of this proactive. I will only cover this section up here, the other emergencies. So, and this goes more or less to the, not just labs, anywhere where you have like any chemicals that are potentially hazardous. If you're trained to work with these chemicals and you know how to clean them up, clean them up. If you don't feel comfortable, if you can't do this, if the amount, if the severity of the incident is too much, it becomes a spill you cannot manage. This is by definition an emergency, and you call, as always, 5555. Safety will coordinate all responses, calling EH&S, calling the fire department, calling our hazardous waste support team. For you, it's important, stop work. It's like basically the race, stop work, alert potentially exposed lab workers. There's a buddy system. As Alicia mentioned, you should not be alone in the lab. If something like this happens, it's overwhelming. You cannot do everything at the same time, so you have to make plans. And in case of an accident, those plans usually don't hold up. So always have somebody present, which is the so-called buddy system. If it's possible, contain the spill, evacuate if necessary, check with safety for guidance, assist in the response or the cleanup. Most importantly, you are the one who used the chemical and you know what it is. You are the one who has access to the SDS or who can ask specific questions about the chemical. If you walk away, nobody knows. It's becoming a long time mystery. If you need medical attention, we go to the next slide and we have a special presentation, and also file your accident report. If in a few cases where we have radioactivity, if it's a radioactive spill, call 5555. They also should contact the radiation safety office. Here's the number. And any spill, little or big, just inform me about this. So if this is a medical incident, so again, report all lab-related accidents incident to safety. I'm not talking about a little, I bumped my shoulder on the door or something. If it's something that involves some blood or something, report this to safety, as it was mentioned before. Just to point this out, Columbia's EH&S team is not the first responder, so do not contact them. We lose trace of the accident because they have a total different system. If it happens under the NISP roofs, meaning in the co-op, on the PARDES or the affiliated buildings, inform NISP by calling 5555. And then the same thing happens. Stop work, alert potentially exposed workers, inform your supervisor, request the SDS or the biohazard information. If you need medical attention, unless it's an emergency, which we'll follow up later, proceed as followed. If you're a Columbia employee, you can go to Workforce Health Services. If this is after hours and then know they close at 4 o'clock in the afternoon, you have to go to the emergency room. If you're Columbia University or Barnard College, grad or undergrad student, go to the respective student health services. If you're an RFMH employee, go to the emergency room. If you're a NISP employee, or if you're a volunteer, considered under the NISP HR department, and you are not Columbia or Barnard affiliate, also go to the emergency room. And then file an accident report. However, the sequence here is important. Report everything immediately to safety. Do not wait for the accident report form to serve as your reporting tool, because certain types of incidents require immediate reporting of the accident to OSHA and other regulatory agencies. This year, I pulled it from some online source, but this happened not too long ago. And somebody used a syringe with a virus solution for a mouse injection. Before the needle hit the mouse, the needle hit the finger. The person thought, okay, fine, this was a clean needle, nothing was in contact with the animal, everything is fine. No report, nothing was filed. The person goes home, and in the middle of the night, the finger turns yellow. After a very sleepless and concerning night, I understand, there was an accident report form, and it goes to Colombia's EH&S team. I got involved, follow up. Yeah, there was a virus in the solution, and the virus was potentially hazardous and a potential reportable agent to OSHA. The biosafety team determined this was not reportable because of, I forget the details, but the point is, there's an 8-hour or 24-hour reporting limit. So if this happened at 6 o'clock at night, and with all the stuff that went down, by 6 o'clock the following day, the gate is closed. So we missed our opportunity, and we are open to a lot of fining and penalties coming our way. So be aware of this and report an incident immediately. Even if it's not that severe, let the pros determine this, but don't take it on yourself just to say, that's all cool, nobody is affected by this. Let the others make the determination. If this was all too much, forget about this. And keep those few numbers, 5555 for emergencies. If you want to call 5100, I tried both numbers. In case of emergency, they both work very well. Kudos to the safety department. If you have any questions about right to know, chemical hygiene, just contact me, my email, call me, swing by my office, whatever works is fine. So, Marshall, are you coming up? Okay, thank you.
As Matthias said, I know that's a lot, but wait, there's more. You guys have been doing, a lot of you have done already, the EEO and the ethics training, and those are both live webinars now. And also we've been sending the Justice Code of Conduct for you all to sign. So thank you for those of you who have done it, but for those of you who haven't done it, we're still going to continue to bother you. You know, if you need group showings of any of the WebExes, we can play them live here in the auditorium as well. So just reach out to us, or if you do a group showing in your area, you can just send us a sign in as well. Okay, and there's the OCFS mandated reporter training. Everybody that's a licensed professional that's required to take mandated reporter training is going to have a new one when they relicense. Anybody that hasn't relicensed since November 22, if they are going to relicense soon. So OMH really wants you to know about that. And if you need that, that mandated reporter training, we have one that's free and available. We can email it to you. So reach out to us if you have to relicense and you need that mandated reporter training, the updated one. And I think the credentialing department knows that too. So, you know, they'll let you know to reach out to them. The New York State procurement card training for anybody that buys anything for their department and on the New York State procurement card, they'll have to take that training. The New York State travel card training they'll have to take, and then safe mail handling. The central office decides by title who takes that training, but anybody that wants it, it's a short video. We can send it out to you as well, and we'll try to make that available on Insight. Dr. Freeman is here, and he's going to also talk to you about calling for medical emergencies, right? So I'm going to give him the podium for a few minutes so he can speak with you all about calling for medical emergencies. Okay.
Yeah.
Was it this one?
No, go down. No, down.
This one?
Yep.
Okay.
Okay.
There we go.
All right. Hello, everybody. I think I'm the caboose, so I'm sure everyone's really had a thrilling morning, and thank you for staying and paying attention. My goal is 60 seconds. So just to let everyone know, NISBE has a medical response team, which means that if there's a medical emergency, you can call 5555 with the pound, and within minutes, there should be a team of doctors, nurses, and other people arrive to help you assess whoever it is and make a determination about what next steps are. Should the patient go to the emergency room? Can they just follow up with a regular doctor? The medical response team is on duty 8:30 to 4:30 on Monday to Friday. Outside of those hours, the DOC, the doctor on call, the resident doctor on call, excuse me, handles medical emergencies. The key point I'd like to make is that it would be our preference if you are in an emergency situation, medical emergency situation, that people actually call a medical emergency rather than call EMS themselves. While calling EMS, one would think will get them here quicker, it's actually more complicated because EMS categorize calls based on what they're told, and that determines how quickly they come. So we actually had someone here who wasn't feeling well. I think of someone working with them called EMS. EMS took an incredibly long time to come. The medical response team came, but they didn't know that that what EMS had been told, and actually ended up causing significant delay in EMS arriving. So unless it's a cardiac arrest, i.e. the patient has no pulse, they're not breathing, in which case you should start CPR if you're trained and have someone call for a cardiac arrest. If someone is urgently medically sick or you're not sure and you want help, then please just call safety 5555 and tell them there's a medical emergency. You should hear an announcement overhead within, 1 to 2 minutes, and the team should arrive within 3 to 4 minutes. Any questions? Thank you very much.
Okay, thank you, Dr. Kreitman. And that leads into my next slide pretty well. So let's go back to this slide from current. Some of you may know that CPR is now required for all patient-facing staff, and that includes human subject research participants. So I've seen many of you in CPR already, but yeah, you can call us at staff development, reach out to us, and we'll set you up with a class either for your team, or we'll put you into an existing class if we have spaces. Okay, and trust or therapeutic relations and universal safety training is also required for anybody that has more than 50 direct care contact hours with patients. So some of the students that come here 2 or 3 times a week for 6 weeks, they just go over that amount of time. And if anybody has any unsupervised contact with patients, then they're supposed to have the trust training as well. And so you can reach out to us for the trust and the CPR training at staff development. Also, an announcement that's going to be coming out soon is there's going to be a new 90-minute diversity and inclusion training that everyone's going to have to take, and then a new 90-minute cultural competency training that direct care staff will take. Last year, our cultural competency training was the CFI, and that's still on Insight for anybody that wants to look at or review it. But we do recommend that everybody does their best to download the CFI. It's a great set of questions for any clinician to know or learn. And it really gets at the heart of seeing the way that the patient looks at their diagnosis, as well as getting to understand their connection to you and their culture and your culture as well. So again, they're tested questions. They're great questions, I think, for any clinician, even research assistants, everybody. I think it will help you if you download the CFI, and you can get that if you go to the American Psychiatric Association's website, DSM, Cultural Formulation Interview, and you'll be able to download that form. And it has the questions, and it also has notes for interviewers on how to give those questions. So it's a great tool. Again, the video on the formulation and the development and research of it is still on Insight, but also if you can please take a chance and download that to your computer. Okay, so and again, I know it was a lot of information. Feel free to contact us at any time, and thank you for listening and your attendance today, and thank you for helping to keep NISP safe, everybody. Okay, and have a nice day. Thanks.